Hello, everyone, and welcome to this ISN webinar. I'm Brad Rovin. I'm a nephrologist at Ohio State University, and I'm happy to moderate part 2 of this series of webinars. This is a combination of the ISN and KDIGO efforts, and we're going to talk about glomerular diseases as the new KDIGO guidelines were just released in Kidney International a couple of weeks ago. Today, we have two outstanding members of the KDIGO Guidelines Committee, Dr. Juan Mejía, and he is from the Autonomous University of Mexico. He is a clinical and translational researcher, and I had the pleasure of hosting him in my laboratory for a year during his ISN fellowship. He has a particular interest in lupus nephritis, and he will be discussing the new guidelines in lupus nephritis with you. Additionally, we have Dr. Keisha Gibson, who I've known for a long time. She is Associate Professor of Medicine and Pediatrics, and she's now Chief of Pediatric Nephrology at University of North Carolina, Chapel Hill. She also has dedicated her clinical and translational career to glomerular diseases, and she especially also likes lupus nephritis, but we used her expertise for focal segmental glomerulosclerosis, which is something, of course, that is really difficult to deal with for all of us, and she'll be talking about FSGS today. And so I would like to welcome Dr. Gibson to start us off with FSGS. Keisha, it's all yours.
Wonderful. Let's see. So welcome everyone, and thank you to the ISN community for this invitation to update you on our 2021 KDIGO guidelines for focal segmental glomerulosclerosis. These are my disclosures, but none of them will impact today's talk. So to help contextualize our discussion today, I really wanted to start with a case presentation. So Sarah is a 4-year-old child with 4 weeks of periorbital edema that has been treated as allergies. Her edema has progressed to now where she now has ascites and lower extremity edema. And her pediatrician completes a workup which confirms nephrotic syndrome with 4+ proteinuria and a low serum albumin. And she has normal creatinine clearance. So you're the treating physician, and you have to decide whether you're going to start her on a fixed dose of prednisone for 4 weeks and taper her to a lower dose for 4 weeks. If you're going to follow the same pattern, but now do this for 6-week increments. If you're going to pursue genetic testing before discussing treatment options, or recommend that she undergo a kidney biopsy before starting anything else. Now, many of you will recognize choice A and B as fairly conventional options. Choice C is hindered by a relative paucity of mutations or known mutations for steroid-sensitive disease. And as it pertains to biopsy, we recognize that the prognosis of childhood nephrotic syndrome is best predicted by the patient's response to initial treatment and the frequency of relapse during that first year. So we typically do not need to start with a kidney biopsy unless children are presenting with an atypical presentation. So that's hematuria, that's hypertension, maybe they're presenting with what appears to be a chronic renal insufficiency picture, or we find them to be steroid resistant. And so with that, definitions are important. And indeed, the KDIGO writing group felt it important to address and refine definitions surrounding steroid responsiveness. So you'll see that there were efforts to make sure that we were very clear in our definitions of what constitutes steroid sensitivity, what constitutes an infrequent relapser, a frequent relapser, those that are steroid dependent, and then that which entails steroid resistant disease. Efforts were made to align the definitions across international guidelines to promote synergy. And this was particularly important because our International Pediatric Nephrology Association was almost concomitantly working on definitions for steroid-resistant disease. So we really wanted to make sure that there was consensus and synergy around these guidelines. So steroid-resistant nephrotic syndrome is defined as a lack of complete remission at 4 weeks of therapy with daily prednisolone at a standard dose. There are specific definitions for a late responder, definitions surrounding calcineurin inhibitor responsiveness and resistance, multi-drug resistance, and then very importantly, a definition to really help us understand secondary steroid-resistant nephrotic syndrome, as we recognize that this particular population is at high risk for recurrent FSGS following transplant. So readers familiar with the 2012 KDIGO guidelines will find the grading grade system, sorry, I have a, move this out of the way, the grade system fairly familiar. So the grade methodology was continued but strengthened by the link between evidence and recommendations. Now, because of this, there are fewer recommendations. The guidelines now include a mix of recommendations and practice points to aid clinicians in the evaluation and implementation of guidance from the expert work group. The practice points were created when there was no review conducted or there was insufficient evidence, or the evidence was inconclusive, or if the consensus decided upon provided guidance based less on evidence, but took into consideration things like benefits and harms, values and preferences, or resource considerations. These guidelines will be published in print form and online in Magic App. And this format will facilitate rapid updates as new evidence emerges. So there are many reasons and benefits for moving towards this idea of a living document. These electronic platforms will provide a streamlined process resulting in increased efficiency and consistency during evidence retrieval and systematic review. There's increased transparency in evidence selection, increased quality control during systematic review, and a centralized content repository and vigorous library management system for evidence retrieval. Digitization facilitates evidence surveillance and guideline updating, and this improves efficiency in guidelines and guideline writing. So our hope is that all of this will enhance implementation and update by clinicians and patients at point of care. So what if Sarah was 26 years old? So not our 4-year-old patient. So we're going to go back to our case presentation where Sarah is presenting with nephrotic syndrome. She has 4+ proteinuria, low serum albumin, normal creatinine clearance, and she's referred to you now as a treating nephrologist. So with her, you have to decide whether you're going to start oral prednisolone at 80 milligrams daily or 120 milligrams every other day for 16 weeks. If we're going to start tacrolimus or cyclosporin, so begin a calcineurin inhibitor and treat her for 6 months. Are you going to pursue genetic testing before you make any treatment decisions, or are you going to recommend that she undergoes a diagnostic kidney biopsy? And many of you will recognize that our standard of care on the adult side is to start with the kidney biopsy. So this is completed for Sarah, and in fact, we find that she does meet a histologic diagnosis of FSGS. So we know that FSGS is a common cause of nephrotic syndrome. Not all patients with FSGS will truly have nephrotic syndrome, and that's going to be a very important distinction as we move forward. It can be associated with rapid progression to end-stage kidney disease. On biopsy, it is characterized by segmental sclerosis and tough collapse and hyalinosis, as we see here in this disease glomerulus compared to a very normal-looking glomerulus. There is segmental, there's effacement of our podocytes, as you can see here, compared to these very healthy looking podocytes. FSGS is responsible for 40% of adults and 20% of children that are presenting with nephrotic syndrome, and worldwide, 8 million people are impacted, and it's expensive. In North America alone, expenditures exceed $40 billion and is growing. So just as steroid responsiveness drives prognosis in children, the prognosis of FSGS correlates with the magnitude and persistence of proteinuria. So observational studies have demonstrated that patients with non-nephrotic range proteinuria may have a 10-year kidney survival rate of over 90% without immunosuppressive treatment. It is for these reasons that the KDIGO working group felt that FSGS with nephrotic syndrome should be separated out as its own entity as primary FSGS, and that since the kidney outcomes of FSGS patients without nephrotic syndrome remain favorable, patients with genetic secondary forms of FSGS or FSGS of undetermined cause should not be treated with immunosuppression. And these, if you can determine one of these causes, that we would not want to subject them to prolonged periods of glucocorticoid treatment. And so again, in patients with FSGS but lack nephrotic syndrome, evaluation for secondary causes should be pursued. We want to consider genetic testing as it may be beneficial for a selected group of individuals with FSGS. And we'll talk about the importance of referring them to specialized centers with the specific expertise to help guide the management and the counseling of these patients. And that immunosuppression should not be used in these patients with idiopathic FSGS without nephrotic syndrome. Really rely on supportive therapies like ACE inhibition and some of our other antifibrotic agents. Due to a paucity of biomarkers, our phenotypic characterization of nephrotic syndrome diseases are largely dependent on histologic classifications, with the common final pathway of many of these glomerular diseases ending with fibrotic changes that easily mimic FSGS. It's easy to see how dependence on these biopsy findings may lead to incorrect diagnoses, or at least phenotypic characterizations that don't match the genotype. So one term that is gaining traction is phenocopy, which refers to a phenotypic trait or disease that resembles the trait expressed by a particular genotype, but in an individual who is not a carrier of that genotype. This term was coined by Richard Goldschmidt in 1935 and originally referred to an environmentally induced non-hereditary phenotypic modification that resembles similar phenotype produced by a gene mutation. So one example of this was in Drosophila, where they found a variety of environmental factors like temperature, shock, or radiation produce these abnormalities in the flies that resemble the abnormal phenotype of known genetic mutations, so a phenocopy. In this cohort of children in the United States, the following list of genetic mutations correlating with these very heterogeneous diseases were found in children that actually had a clinical diagnosis of FSGS. So imagine how the treatments of these patients may have differed having this information on the front end, how their outcomes may have differed. We have enzyme replacement therapies for patients with cystinosis and Fabry's disease. So having this information on the front end may in fact really impacted their overall outcome. Just a few years ago, Groupman et al. Reported their experience in this exome sequencing analysis of over 3,300 ethnically diverse patients that were over 21 years of age with CKD. So these are adult patients with CKD. About 10% of these patients had a genetic cause, and if you focus here on the COLA4A mutations, 62% of them were misdiagnosed with other things like FSGS, or not diagnosed as having Alport syndrome or thin basement membrane disease. So these results illustrate the potential for genetic findings to provide new clinical insight. It may alter medical management, or in some cases, influence the choice of therapy. You are not going to inundate somebody with prolonged periods of immunosuppressive therapies if you know they have a type 4 collagen mutation. Now, traditionally, we consider the high yield populations for genetic screening to include children, and in particular, children less than 1 year of age, and in families where there is a family history of FSGS. But these data would also extend the question of the utility of genetic testing for steroid-resistant nephrotic syndrome, or FSGS, into early adulthood. So many of you on this call are very familiar with APOL1. which encodes the protein apolipoprotein 1, which lyses trypanosomes, the organisms responsible for causing African sleeping sickness. It is only the disease-associated APOL1 variants G1 and G2 that can lyse a very resistant strain of this organism, Brucei rodensiense. If you note in this diagram, individuals with 0 copies of the alleles succumb to the disease. 1 copy confers a heterozygous advantage, but 2 copies confer a homozygous disadvantage with an excess risk of chronic kidney disease progression. So the evolution of APOL1 variant has been postulated to be a critical survival factor in certain parts of the African continent. And if you look at African Americans here in the US, about 12 to 15% have a high-risk genotype where they're carrying 2 copies of the disease alleles. There are genetic admixture studies that demonstrate that the presence of this high-risk genotype may in fact explain up to 42% of the excess risk for end-stage kidney disease in individuals of African ancestry. As a pediatrician, I pay very close attention to this because this is a disease of young people. It has been found that FSGS disease progression begins early, and early meaning age 15 on to 39, and over 70% of individuals that carry this high-risk genotype. So when to think about genetic testing? Obviously, when we have a family history, you're looking at your patient and their syndromic features, but we also want to think about this in young adults. Genetic testing can be very useful in helping us when we are trying to provide guidance to living donors. If we know that they have a high-risk APOL1 genotype, maybe your counseling will differ. In families that are looking for guidance in family planning, it may help with how you discuss future risk with these individuals. Again, in order to do this correctly and safely and ethically, this should be done by centers that have the correct expertise with genetic counselors to really help interpret the information that is being collected. So if we go back to our treatment algorithm, what about those individuals that may move from non-nephrotic pictures to a nephrotic picture with worsening proteinuria and low serum albumin, or those that present with nephrotic syndrome? In these patients, we're going to recommend that those are the ones that get treated with immunosuppression. And so some background information on the observational studies that really went into this recommendation. Despite 20% spontaneous remission rates, FSGS patients with nephrotic syndrome clearly have a poorer kidney prognosis than those without nephrotic syndrome, with their 10-year survival rate reported around 57% versus the 90% that we discussed for those without nephrotic syndrome. So in this study of 281 nephrotic FSGS patients who were identified through the Toronto Glomerular Nephritis Registry and followed over a period of 65 months, a greater renal survival in those that achieved either a partial remission defined as a reduction in proteinuria by at least 50%, and complete remission defined as a urine protein creatinine ratio of less than 0.3, renal survival was much higher than those that displayed no response to therapy or no remission status. So with this in mind, and again, based on largely observational data, the working group provided this 1D recommendation to use high-dose oral corticosteroids as a first-line treatment for idiopathic FSGS with nephrotic syndrome. The working group is recommending that prednisone be dosed at 1 mg per kg per day to a maximum of 80 milligrams, or an alternate day dosing schedule of 2 milligrams per kilogram per day, alternate day. And that this is continued for at least 4 weeks until complete remission is achieved, or for a maximum of 16 weeks. So this is high-dose corticosteroid exposure. Once remission status is determined, or you're at the 16 weeks and there's a response, then the recommendation is to taper this over a period of 6 months. There's guidance here that patients who are likely to remit will show some degree of proteinuria reduction before 16 weeks. And so again, based on observational study, there was no information that we could find that would recommend extending the exposure beyond that 16-week period. In patients with a relative contraindication or intolerance to corticosteroids, alternative immunosuppression with calcineurin inhibitors should be considered as initial therapy. So think about your patients with diabetes, your patients that are battling obesity. Maybe your patients have had previous exposure to steroids and have had steroid-induced psychosis. And these individuals, initial therapy with calcineurin inhibitors would be recommended. And the working group has provided some guidance in regards to trough levels to target. So again, definitions matter, and the working group collated information to try to provide some consensus building around these definitions. So again, we're talking about those FSGS patients with nephrotic syndrome, and defining complete remission in this group includes both proteinuria reduction to a UPC of less than 0.3 and resolution of hypoalbuminemia with a serum albumin of at least 3.5. Partial remission is based on proteinuria alone, with a reduction in proteinuria by at least 50% from baseline. And then there are specific definitions for relapse and then what constitutes steroid-resistant FSGS. So moving on to the next recommendation for those adults with steroid-resistant primary FSGS, we're recommending that cyclosporin or tacrolimus be given for at least 6 months rather than continuing with glucocorticoid monotherapy or not treating at all. So you've hit that 16-week mark with steroids, you're not getting a good response, it's time to move to a calcineurin inhibitor. And as a practice point to follow along with this, adults with steroid-resistant primary FSGS who do respond to calcineurin inhibitor, we are recommending that they be continued for a minimum of 12 months to minimize the risk of relapses. So before if you find that you have a good response, really recommending that that treatment is continued for at least a year before you consider weaning therapy. So let's go back to Sarah. So because Sarah's FSGS presented with nephrotic syndrome, she was started on oral prednisone at 80 milligrams daily and stayed on this for 16 weeks without a reduction in proteinuria. So she was determined steroid resistant. She was then started on tacrolimus, and her physician targeted an average trough level of 8 nanograms per ml, so fairly moderate trough level, and then weaned off steroids. She stayed on tacrolimus for 6 months, but only achieved a slight reduction in proteinuria and remains nephrotic. These are the cases that we all hate, but we see. And the question is, what do you do next? And we now find ourselves where is looking towards our specialized centers for consideration of alternative treatments. And in looking at the clinical trial data that is available, the working group did not feel that we could provide a specific recommendation for what to include next. So this is when you want to bring in the experts because the care is going to be individualized at this point. And this is also the point where we really want to push the importance of enrolling in clinical trials. We find ourselves in the midst of great opportunity. We have a lot of industries that are partnering with our community with new therapeutics. And so it's really important that we work hard to get this population of patients enrolled in these studies so that we can determine what our next best therapeutics are for them. So there's a lot of opportunity moving forward. Clearly, we need to identify biomarkers for steroid-sensitive primary FSGS. We want to know which of those patients are going to respond to that therapy best. But we need new treatments for our steroid-resistant and calcineurin-resistant patients, and we need new biomarkers to be able to follow them. But in addition to that, we need studies that will really help us evaluate the efficacy and adverse effects of glucocorticoid treatment. You know, is daily better than alternate day or vice versa? We need to better understand the optimal duration of steroid exposure in adult patients and to compare remission, relapse, and adverse event rates. We need to evaluate the effectiveness of calcineurin inhibitors with and without concomitant steroids. We need to understand the optimal duration of calcineurin inhibitor exposure in these patients. And then other therapies like plasmapheresis and LDL apheresis in the treatment of primary FSGS and the prevention of recurrent FSGS following transplant. All of these are opportunities for randomized controlled trials to better guide our decision making for this very special group of patients. And with that, I'm going to close and pass the baton to my esteemed colleague, Dr. Mejía.
Thank you very much, Professor Gibson. Thanks to the ISN for the invitation to this webinar, and thank you all for being here today. So we will now move to the lupus nephritis chapter. And before starting, there's no conflict of interest from my part to this talk. And first, I want to remember this that was already mentioned by Professor Gibson. This new KDIGO guidelines has statements that are classified as recommendations, and these recommendations are based on enough evidence from randomized clinical trials, and they apply to most of people with this disease and everywhere in the world. And the other hand, practice points, these were created for areas where there is not enough evidence or even no evidence at all, but we all need guidance. So with this in mind, we will try to go through all these points in the lupus nephritis guideline. And first, we will start with diagnosis of active lupus nephritis. I always like to start the talks in lupus nephritis recalling the phases of lupus nephritis. So first, we have a patient with systemic lupus, a patient who lost self-tolerance to antigens and has autoimmunity. And these patients usually start developing immune complexes that deposit in the kidneys, first in an asymptomatic manner, and this is what is called silent lupus nephritis, and it's difficult to diagnose. Usually we need a kidney biopsy. What we usually see in clinical practice is the inflammatory phase of the disease, and this is manifested by activity in other systems, but in the kidneys we usually see proteinuria, hematuria, decreasing kidney function, low complements, and positive anti-double strand DNA antibodies. So these 5 laboratory tests are the one that we need to test our patients for at diagnosis and then at follow-up. And especially proteinuria and urine sediment aid us to suspect lupus nephritis. And if we find positive proteinuria in the urinalysis or a positive urine sediment, then we must proceed to quantify proteinuria, especially by a 24-hour recollection. And if the proteinuria is above 500 milligrams per day, then most of the panel for the guidelines would consider a kidney biopsy. On the other side of this algorithm, we must remember that lupus nephritis can also present as decreasing kidney function without other features. And if this is repeated persistence and there's no other cause for kidney failure, then it can also be an indication for a kidney biopsy. So going back to this phase scheme, we have a 4th phase in the natural history of lupus nephritis, and that is a repair or fibrotic phase, depending on response to therapy or if the patient continued the natural course of the disease. And the problem here is that this chronic kidney disease phase manifests with very similar findings as the inflammatory phase. We may have reduction in kidney function, we may have proteinuria, and even sometimes we can have hematuria. So differentiating between active disease and chronic disease is crucial. So in this new guideline, the consideration for a kidney biopsy is still high because we need to differentiate active disease and chronic disease. And if you can see this algorithm for class 3 and 4 lupus nephritis, you can see that at the start, the first thing is to assess activity and chronicity in the kidney biopsy. And this is highly important as chronic kidney disease has to be managed with supportive therapy and no immunosuppression. And active lupus nephritis obviously needs immunosuppression. So to evaluate this, you need to go through all the kidney biopsy report and especially look for all the activity items that we know and all the chronicity items. So it is not just the conclusion from the nephropathologist, but you have to read the full report. And these activity and chronicity items may be summarized as the activity and chronicity indexes, although there's high variability between nephropathologists, and this is not widely accepted. So it is recommended to go through all the activity and chronicity items so you can define if your patient is a candidate for immunosuppression. So once you know there is active lupus nephritis, before starting immunosuppression, there's a suggestion to take some time, evaluate the individual risks for your patient for complications, and start adjunctive therapies. And this is because you can see in this slide that 20 to 20% to 25% of patients in recent clinical trials have serious adverse events from therapy. And many of them are serious infections. Unfortunately, there are few deaths in the late clinical trials. And sometimes there's no need for a very serious adverse event, but patients are worried about some other cosmetic issues. So we need to evaluate our patients before starting immunosuppression. And I will now go through this big table, but we need to evaluate the cardiovascular risk. We have to start all the proteinuric treatments, and especially we have to go through the infectious risk. For example, we have to evaluate if patients have had herpes zoster previously, especially if we want to use a therapy based on mycophenolate or a triple therapy. We have to go through vaccination, and there's no better example than this pandemic to consider how the pandemic is going up or down to start immunosuppressive treatment. We have to go through other risks, for example, bone disease, ultraviolet light exposure, and we have to know our patient preferences regarding contraception and pregnancy expectancies. So this is a very important point before starting treatment. And the other therapy that is now recommended for every patient is antimalarials. Antimalarials have not been evaluated in large clinical trials. However, observational evidence is large, and there's evidence for mortality reduction, for thrombotic risk protection, for less relapses. So with all this evidence, the panel recommended to use hydroxychloroquine or chloroquine for most patients unless contraindicated. And of course, these patients have to be evaluated by ophthalmology at baseline and then every 5 years. So now we have our patients who is active. We evaluated the risks for complications. We can now go to immunosuppressive therapy. And the cornerstone for immunosuppression in the years of treatment of lupus nephritis is glucocorticoids. So what is new for glucocorticoids in this new guideline? We usually dose glucocorticoids at 1 milligram per kilogram per day, prednisone equivalent dose, and then we try to taper to low dose by 12 to 16 weeks of therapy. But there are dose-dependent adverse events from glucocorticoids, and there are time-dependent adverse events. So in the latest clinical trials and in some hospital protocols, as Las Cruces protocol, for example, we have seen in the late years that by administering methylprednisolone pulses, this allows us to start with lower oral doses of glucocorticoids. This is 20 to 25 milligrams per day. And if we start at a lower dose, then we can taper faster to low dose by 12 weeks of treatment. And for this reduced dose glucocorticoid scheme, there is some evidence. There's a clinical trial, very small, the My Lupus clinical trial, that showed equivalent responses with a standard dose and a reduced dose glucocorticoid scheme. We have the voclosporin phase 2 and phase 3 trials, where the dose of oral glucocorticoids started at 25 milligrams and then was tapered down to 5 milligrams by 12 weeks. And we know that there are even some treatment schemes that use no oral glucocorticoids with very satisfactory response rates. But we don't have randomized clinical trials, as happens for ANCA vasculitis, for example. So this is a practice point, and the panel considers to suggest to use a regimen with reduced glucocorticoid dose as initial treatment for lupus nephritis. You have to consider this for your patients, and by a reduced dose scheme, we refer to use of methylprednisolone pulses followed by oral prednisone at 20 to 25 milligrams per day, and then go down to 5 milligrams by 12. So along with glucocorticoids, we need to select another immunosuppressive drug. And for this, for class 3 and 4 lupus nephritis, we have 4 options now. We have calcineurin inhibitors, we have mycophenolate-based regimens, we have cyclophosphamide, and we have B-cell therapies. I will start with mycophenolate and cyclophosphamide, as still these are recommended as the first-line therapies. And as I need to remember you to recall that recommendations need to apply to most patients and need to apply worldwide. And this is an important issue for this. And why are still cyclophosphamide and mycophenolate the first-line therapies? Well, here you have a scheme of the natural history of lupus nephritis. You know, there are some flares and then responses. And regarding kidney function, it takes a long time for kidney function to go down. And the usual clinical trial only lasts for 6 to 12 months. And the newer clinical trials now have lasted for 2 years. And they usually evaluate responses to therapy. What we need for a drug to be recommended as a first-line therapy is to demonstrate an efficacy to prevent loss of kidney function, and that is hard outcomes of decrease in kidney function. So for low-dose cyclophosphamide and mycophenolate, we already have data of that long-term follow-up. We have learned how to use them. We know their safety, and this does not happen for the newer therapies, and I will talk about that in the next slides. The novel treatment schemes, and by novel treatment schemes, I refer to CNIs, combined therapy, and B-cell therapies, have still some questions. So starting with calcineurin inhibitors, you can see that now voclosporin or tacrolimus added to mycophenolate and glucocorticoids is an option of therapy for patients with eGFR above 45 ml per minute. You know, there was a large trial in mainland China that demonstrated this combination therapy, and this voclosporin trial that was published recently demonstrated, as you can see in the blue bars, that the combination therapy with a calcineurin inhibitor had higher complete renal response rates compared to a mycophenolate and glucocorticoid treatment. And probably the most exciting result from this trial is that proteinuria goes down very fast. 50% of patients decreased their levels of proteinuria by half by 1 month of therapy. So with this result, why is this not yet a first-line therapy? Well, the thing is that we still need to learn better for these treatments, which is the best population to use them. And here I show you a subgroup analysis from the Aurora 1 trial, the voclosporin phase 3 trial. And you can see that in patients without previous mycophenolate treatment, there was no added benefit of adding voclosporin against only treating with mycophenolate and glucocorticoids. So there is a subgroup of patients that may benefit from this treatment, and we still need to learn better about this. We need to have long-term results on kidney function, and there are many questions for CNIs, as for example, how long are we going to use them? How are we going to taper them? So we need these answers before recommending this for everyone or as a first-line scheme. The other novel therapy scheme is the B lymphocyte targeting biologics, and especially belimumab added to mycophenolate or cyclophosphamide. As you know, the BLISS lupus nephritis trial showed that belimumab added to this standard of care treatment had better complete responses by 1 year and by 2 years of treatment. And the most exciting result from this trial, from my perspective, is that belimumab prevented relapses in all subgroup of patients. So this is a pretty good therapy that may aid preventing relapses. So why is this still not a first-line therapy? Again, just as happens for CNIs, there are still some subgroup of patients that we need to learn if this therapy is adequate. And for example, in this sub-analysis, you can see in these red arrows that in patients who received cyclophosphamide as induction, there was no added benefit of belimumab. For Black patients, the group was very small to study. And for class 5 and patients with higher levels of proteinuria, there was no added benefit of belimumab. So we need to learn who's the best patient to treat with B lymphocyte therapies. We need to know for how long to use them, and we need to know the long-term results. And of course, in the next years, we will have these results. And if these are good enough, probably these two therapies will go to a first-line recommendation. Okay, so now once we give therapy, we need to assess response to therapy. And this is an important point because we know that in lupus nephritis, proteinuria usually takes a long time to disappear. And this is an example in the yellow bars of a patient with more than 3 grams proteinuria, patient with nephrotic range proteinuria. And it may take up to 2 years for this patient's proteinuria to go down below 0.5 grams per day. There are many studies showing that a limit below 0.7 to 0.8 grams per day by 1 year is a good target for patients with high proteinuria. So probably by 6 months and even at 3 months, the level of proteinuria is not going to go down so fast in most patients. So having a decrease in proteinuria of 25% may be enough at 3 months to know that this patient is doing well, and we need to give them time for proteinuria to disappear. So the remission definition is pretty similar to previous guidelines with stable kidney function and a limit of proteinuria below 500 milligrams per day for complete remission. But you have to see that there is a time threshold, and there may be 12 months, but it may take more time for proteinuria to go below 500 milligrams per day. And this is also underlined in the Euler guidelines. If you read the Euler guidelines, it says that proteinuria should go below 500 to 700 by 12 months. But if you have nephrotic range proteinuria, the response period may extend 6 to 12 months, up to 18 to 24 months total. So we need to be patient with proteinuria and classify patients with no response, those patients whose kidney function is deteriorating, or patients whose proteinuria is going up or not responding at all. And in these patients, we have no recommendation but a practice point algorithm, and we need to verify if they are taking their medications. If we have the option to measure MMF levels or hydroxychloroquine levels at our center, we may do that. We may need to repeat kidney biopsy to be sure that this is active disease and not just a chronic kidney disease, as I was mentioning. And if there is active disease, then we can consider switching to another first-line therapy or then go to the second-line therapy. And finally, maintenance therapy. This maintenance term probably will disappear in the next years, but we still use it. Our aim is to prevent relapses, and for that, we still use glucocorticoids at the lowest possible dose, along with mycophenolate as a first choice. In some scenarios, and for individual cases, we may use azathioprine, especially for patients looking for a pregnancy. And if these two medications cannot be tolerated, then we may use CNIs or Mysoravine. And this treatment should go up for at least 3 years before trying to suspend therapy completely. And finally, there are additional scenarios in lupus nephritis. I will go through all of them, but the thing is that there are rare presentations of lupus nephritis, and we all need guidance in these scenarios. So for example, you may find an algorithm for class 1 and 2 lupus nephritis patients, especially those with nephrotic range proteinuria, where you have to exclude lupus podocytopathy. There's an algorithm for class 5 lupus nephritis, where now Rituximab is considered as an option for treatment. And I really like this one. There's an algorithm for lupus nephritis and suspected thrombotic microangiopathy. And we know this is an emergency. So we have an approach to an emergent treatment. And then this algorithm looks to find the etiology for the thrombotic microangiopathy, so you can select an adequate treatment for that specific etiology. So with this, the take-home points from the new KDIGO guideline in its lupus nephritis chapter are the following. Before starting immunosuppression in a suspected lupus nephritis patient, you have to be sure that lupus nephritis is active, and if you are not sure, you may consider a kidney biopsy to evaluate histology. Then you have to assess the individual risk for complications in your patient and start preventive therapies. Start an antimalarial if there's no contraindication, and then you can go to immunosuppressive treatment. And for this, you need to select an appropriate dose of glucocorticoids. Many patients can be treated with a reduced dose scheme. First-line therapies, this is a recommendation for everyone, are still low-dose cyclophosphamide and mecophenolate. We discussed this, but we have novel treatments that are very promissory and probably will demonstrate effectiveness, but we have to be cautious about this and wait until we have all the responses to most of our questions. To assess response to therapy, we have to know that proteinuria resolution is frequently slow. And of course, the aim of this guideline is to help you treating your patients. So there are several other aspects covered, most of them as a practice points, as we don't have clinical trials for everything, but hopefully this will guide your practice and will help you in difficult situations. So with this, this is all from my part. Thanks for your attention, and I am ready for any question.
Okay, this was great. Thank you both, Keisha and Juan, for really extensive, insightful, and wonderful presentations. So we have a very large number of questions on the board, and thank the audience for being so engaged and submitting their questions to the question box. We will not get to every question, so I'm going to say that right now. However, you submit your question with your email, then after the conference, the two speakers will try to address your questions. So let me pick out some general ones. I've been watching the questions come in, so some themes have developed. So, Keisha, this keeps coming up, and this is really hard, and I think we really need to discuss this. How do you really detect the difference or understand the difference between primary and secondary focal sclerosis clinically? And in areas of the world, this guideline applies to the whole world, where a biopsy might take a while, or where you have no ability to do genetics, what do you do?
Now, this is a great question, and there was a lot of conversation generated among the KDIGO committee members because traditionally we've had segments that really wanted to put in features of the biopsies to really help us determine what is primary versus secondary FSGS. Many of you are familiar with looking at markers like global podocyte effacement, if podocytes were 80% effaced or less. And because of the need to consider global resource availability and the subjectivity of really looking at those biopsy markers, the working group really settled on those clinical markers that should be globally accessible. So you'll know if your patient is hypoalbuminic or not. Do they, are they truly nephrotic? Do they have urine protein excretion of more than 3.5 grams? And so the work group really settled on that and sort of avoided some of these other features that may bring in a level of subjectivity or just not be something that is readily accessible to the global community in terms of helping us to determine primary versus the other causes. And then at the end of the day, you look at your patient. Are there other things that will help you determine if this is a secondary process? So you want to pick up, as a pediatrician, I'm always cognizant of looking for syndromic type abnormalities. If it's subnephrotic range proteinuria, likely this is not going to be the immune mediated primary FSGS that we are trying to carve out. If there a family history, is there anything else to lead you down that genetic path? Have we been thoughtful to make sure that we're paying attention to a viral history? Should we be assessing for different viruses, hepatitis? Think about where you are in the world and things that are endemic. So, all of those are very important considerations, but for our determination with these guidelines of primary FSGS, we're really focused on those clinical parameters of hypoalbuminemia, true nephrotic syndrome.
Okay, and thank you, Keisha. So obviously, some of the things she was talking about that really weren't included in the guidelines, and really because they can't be done all over the world, one of the features of primary FSGS, we think, is sort of diffuse foot process effacement on electron microscopy, and that is also a helpful clue if you have access to that. But I think, Keisha, in your talk, what you said was we need biomarkers that are robust, maybe urine or serum biomarkers that could be easily applied to this when other resources are not available. Okay, I'm going to give Juan the next one. There's a lot of, I'm combining a whole bunch of questions. So these were sort of, how long do you treat? How and when do you withdraw? How would a repeat kidney biopsy potentially help you in managing patients long term? And can we get patients off immunosuppression? So a lot of different ideas, but I think they sort of focus around a point.
Okay, that's a difficult one because we don't have a lot of information, but Of course, there's an option to suspend all treatment. The Italian series have demonstrated that we can. But you need to know where you are in the world. For example, at our center, there are very few patients who can suspend all the treatment because they frequently relapse. So the first point is, it is very important to have information from your own center and how the patients are having results in your center. Because the Italian series have shown that if after 3 years you go down, you taper down therapy, and you may suspend in up to 30% of patients. So the second point here is, at least you need 3 years of therapy, because that was the predictive time point for success in the Italian series. Regarding the protocol biopsy, of course, we don't have effective biomarkers to show us where is activity and where is chronic kidney damage. So there will always be a role of kidney biopsy in these situations where we have clinical doubts, and some use them even before pregnancy, for example. But going to the scenario of suspension of therapy, of course, the works from Ana Malvar in Argentina and Dr. Rovin here showed that if you look at the kidney biopsy, you can see what patient is going to relapse. If there's still activity, especially in the stool interstitium, there may be some plasma cells in there, memory plasma cells, that may produce a relapse. So kidney biopsy may be very helpful. We don't have hard evidence to recommend it, but it's another tool to try to suspend therapy in our patients.
Okay, so a couple of things for the audience. Handouts have been attached and they're available, and these are the presentations in the PDF form. We are allowed to extend our question and answer period beyond the hour. So if you want to stay on, and I see there's a number of people still on, I'm going to keep this going for just a little bit more time because these are important and hard questions, and I'd like you all to have the speaker's expertise. So, Keisha, there were a number of questions on alternative therapies for FSGS, and I know sort of towards the end you said, well, you know, when you get beyond calcineurins and steroids, it's time to do clinical trials, and it's also time to go to an expert center. But one that keeps coming up is Rituximab. What are your feelings about Rituximab in FSGS?
Yeah, so Rituximab is a difficult one. We have clinical trials, small randomized trials that basically give us sort of a zero-sum game, if you will. There have been some trials to show some utility in inducing remission in some patients with adult patients with FSGS, and others that say the exact opposite. And honestly, with these clinical trials, it's a matter of numbers and being able to have a well-powered study. In pediatrics, our studies, when you put them together for rituximab and steroid-resistant disease, FSGS primarily as the clinical phenotype, there really doesn't seem to be a role for rituximab in that patient population.
Okay, so I'd just venture to say for our community as a group, one of the issues with clinical trials in FSGS has always been that, you know, FSGS is not a disease, it's a histologic pattern. And, you know, if you have people with genetic FSGS and people with secondary FSGS and people with primary FSGS that you're then subjecting to immunosuppression, maybe the trials are too heterogeneous, and we really need to, you know, consider how we enroll a trial. I'm going to throw this one to Juan, and then I'd actually like Keisha to come back with it. This is a very topical question for nephrology. SGLT2 inhibitors, what are you doing with them in your patients with lupus first, Juan, and then Keisha in your patients, and are you using them in kids? So Juan, you first.
Okay, so the DAPA-CKD trial did not include diseases that are relapsing. So ANCA vasculitis and lupus are not included in that trial, and possibly they won't be included in future trials. So what's the role for these SGLT2 inhibitors? they work, I think, they work for chronic kidney disease and proteinuria that is not from an inflammatory etiology. So if you are sure that your patient has a chronic kidney disease, that proteinuria sometimes is called residual proteinuria, then I would consider using these medications along with an ACE inhibitor or an ARB. However, there's no evidence at all. And there will not be because these reasons, because these are relapsing diseases and they're not good for the results of the trial. So in short, so the short answer is I will use them only if I am sure that this disease is chronic and that proteinuria is there because of chronic kidney disease, but that is an individual opinion.
I'm going to support your individual opinion because this question has come up in my lupus clinic quite a bit, and we are biopsying patients who have persistent proteinuria. If there is no further activity, there's only chronicity left, so they are truly CKD without need for immunosuppressive therapy. We have been starting SGLT2 inhibitors with RAS blockade. All of the studies were done with RAS blockade. So I think this is something that we're going to have to deal with as a community and understand what to do. But certainly, you know, lupus eventually is CKD. Lupus nephritis is a CKD that can progress, and we want to slow progression over time, and this might provide another tool. Keisha, what are you doing with FSGS, and what are you doing especially in kids?
Yeah, so unfortunately in pediatrics, we have no data for children under the age of 18. So we don't have access on information on how to use these agents, but there are trials in progress. And we're itching for those results because honestly, this is the opportunity, right, to prevent chronic disease down the line. One of our missions as pediatricians is to allow these kids to transition into your adult clinics in the best possible state of health. And so we are very much looking forward to being able to use this as an arsenal for antifibrotic therapies. But I do think that there's going to be a huge role, and it probably will rival the role that we have for RAS blockade.
Okay, let's go another just couple minutes. This is also a topical question. I'm going to toss this to Juan and then Keisha. When is the best time to vaccinate patients? And I think, of course, we're all worried about the pandemic and vaccination in patients in whom we are giving a lot of immunosuppression. So Juan, what are you all doing?
Okay, so the response to vaccination is not good when glucocorticoids are about 10 milligrams per day. And the other drug that has demonstrated that goes against the development of antibodies is Rituximab. So what you need to assess, or at least that is what we do, is how fast is the disease going? If this is a nephritic syndrome, you cannot wait. You need to start therapy and preserve nephrons. But if you have time, there's some proteinuria in there, and you have time to vaccinate your patients, you need to do this before starting immunosuppression and hope for the patient to develop antibodies in 2 or 3 weeks and then go and treat your patient. But also, for lupus nephritis especially, there is evidence that not treating lupus nephritis is also a predisposing condition. An active lupus nephritis predisposes you to severe COVID-19. So we need to treat these patients. The point is, you need to select the best moment to treat them. And if you have time, probably you need to give the vaccine before going up with the drugs.
And one other thing that we're advising our patients is if you're the patient, your circle of family and friends should be vaccinated so that you sort of build a wall of immunity to protect you, and of course continue good hygiene precautions. Keisha, what about your population, especially now with Delta and the kids are getting infected, at least in the United States, I assume all over the world? What is your thoughts?
Yeah, so you already mentioned one of the key pieces that we try to counsel our families is that you have to provide that wall of protection around the child. And especially now, we don't have emergency use authorization for children under the age of 12. And so there's no access to vaccine for them yet. Hopeful we'll be there in a month. And so that part is critically important. And I completely agree with Juan. The response rates to vaccines once patients are on, these B-cell depletive therapies, if they're on high-dose steroids, it's clearly blunted, but it's still worth doing. And so I don't withhold the recommendation to move forward with vaccination. I truly believe that there are some features of adaptive immunity that probably they can respond to that's not completely dependent on the B-cell response to these vaccines. So it's still worth doing. The guidance around the world, the availability of vaccines around the world is clearly different from country to country. But if you are somewhere where there are opportunities for your patient to qualify for booster vaccination, definitely we've been advocating very strongly that this population receives that. So yes, I think that is challenging. We know the response is going to be blunted, but anything we can do, I think we have to.
Okay, and I agree, and I think that one of the issues is, of course, if you do vaccinate, and this can be for all vaccinations, but of course the COVID is the one that's topical right now, and then you immunosuppress the patient, the antibodies also disappear or go down substantially. But a key point that you said, Keisha, which I think is really important, is you still have provoked with the vaccine the T cell system, so adaptive immunity may still provide you with some benefits. Okay, well, to the audience, thank you. Over 300 people have remained on beyond beyond the hour, which shows you the interest in the topic. And we appreciate your engagement over time. Over the next week or so, we'll try to get to answer some more of these questions. And then I want to thank the ISN and the KDIGO organization for providing this forum for us to discuss these new guidelines. And of course, over part 1 and part 2, we've only hit on 4 chapters of the new guidelines, so I'm sure there'll be more. And finally, I'd like to thank Juan and Keisha for excellent talks and in helping prepare the guidelines, which I think are going to benefit people all over the world, including our patient population. So everyone, have a good rest of the day and a good weekend. Bye-bye.
Thank you.
Thank you all.